Hi, everyone. My name's April Demito. I'm your instructor for Women's Health, and this is our study session for the final exam. In going over all of the material, there's a great deal of material covered on this final, going way back from the beginning. I don't think you're going to get much help from the PowerPoint presentations in themselves. I think you're going to get more help by going over the information in your textbook. I'm going to go over some topics that I think are important for you to focus on as you are studying for the final exam. So, urinary tract infection is the first topic of conversation, and um, women are at a greater risk of developing urinary tract infections than men. And reason being is that their urethra, a woman's urethra is shorter, and it is more likely for bacteria to move up into the bladder through the external genitalia, and this can happen from the act of sex. It can happen from wiping from the wrong way, from back to front. I've even had patients that have developed urinary tract infections from sitting in swimming suits too long or from bicycling too much. So there are a lot of causes for urinary tract infections. And you'll see these in women most often. If you were to see a urinary tract infection in a man, actually, that's concerning. Because of their longer urethra, it's not common for men to develop urinary tract infections. So when patients come in, there are a lot of things that we need to consider where urinary tract infections are concerned. Um, we generally will do a dipstick on them to determine whether or not they have an infection, showing leukocytes. We want to clean catch urine, of course. Leukocytes or nitrates. Those are the things you'll see when a urinary tract infection is present. And however, it doesn't always work that way. Sometimes you'll dip the urine and it doesn't look that bad. It may only have a trace of leukocytes. The standard of care is actually to treat the urinary tract infection whether or not the dipstick looks terrible. If they have symptoms of a urinary tract infection, I'm going to treat them. Do I always send a culture out on my patients? No. Cultures are expensive. Not everybody can afford to pay for one. Not everyone has insurance. However, if the patient has recurring urinary tract infections, is very symptomatic, or the dipstick looks beautiful, I'm going to send a culture out. And let's see, if they are really sick and they've got a fever, once you get them on antibiotics, usually within 48 hours, it's better. This temperature's gone down, their symptoms have gotten a little bit better. And as we get older, it increases our risk of urinary tract infection, actually goes up. And there are a lot of reasons for that. Striated muscle fibers kind of weaken as we get older. And also, the lack of estrogen in our body predisposes us for developing urinary tract infections. Well, why is that? Estrogen is responsible for providing us with the lubrication that we have down there. And the drier we are, the more likely we are to develop urinary tract infections for a couple of reasons. That lubrication doesn't help wick that bacteria away from the urethra. And also, there is a probiotic called Lactobacillus. It's a normal bacteria, it's a normal flora that's on the external genitalia. It helps keep our genitalia healthy. And as we get older and as our moisture depletes, that lactobacillus reduces in numbers, and that can also predispose us for developing UTIs as we get older. So, just a side note, if I have a patient that's coming in with frequent UTIs and they're postmenopausal, I instruct them to begin taking lactobacillus on a daily basis. You can tell them to eat yogurt, but in reality, they need to eat a minimum of 3 containers of yogurt a day. For someone to be compliant, that's a lot of yogurt. So, taking the lactobacillus seems to be the better way to go about it. Also, if they're extremely dry down there and they're having difficulty with intercourse, it's painful, um, they can be prescribed a estrogen cream. Now, of course, they can't have a history of breast cancer or strong breast cancer in the family, but that estrogen cream will help to increase the lubrication down there. Not only will it help reduce urinary tract infections, but it also makes intercourse much less painful. So, some things to consider regarding urinary tract infections. Okay, moving on to the next slide, the patient interview. I have to say, speaking with your patient and sitting down is one of the most important parts of the exam process. Um, you have to interpret their body language from the time you see them until the time they leave. And they are also picking up on your body language. Are you tense? Do you seem as though you're distracted? Are you not giving them your full attention? Are you interrupting them? So it's important to provide an environment for your patients that makes them more open to conversation so that they'll tell you those things that they may not entrust in other people. So you really need to provide an environment that's conducive. I have a friend of mine. She has absolutely the most conducive practice you can possibly imagine. She keeps Bath and Body Works stuff in the bathroom. If you go into the restrooms, they look like a home bathroom. She doesn't use paper gowns. She uses nice, warmed gowns for her patients. It's just the whole environment of her office makes you relaxed from the minute you walk in. So you have to consider if a woman is coming to you with her care, for care from you, and she's going to get a vaginal exam and potentially talk about sexually transmitted infections, you really need to have an environment that is conducive to such things. The most common cause for women coming to see you for gynae treatment is changes in menstruation, whether they're skipping periods or in that perimenopausal phase when they get periods that never go away. Um, so, again, I go back to the type of environment that's conducive for patients to be open and tell you what's going on with them. In addition, you'll get a lot of patients that are coming in with uterine bleeding. You have to ask them a whole bunch of questions. I want to know what you're taking and in the history. Um, and don't forget, you need to ask them about any holistic medications that they're taking, herbs, vitamins. And ginkgo actually has been found to have a correlation between abnormal uterine bleeding. So we need to know those things. And in addition, patients may be coming to you with sexual dysfunction. You may think that men are the only ones that are concerned about that. Well, they have their Viagra that they can take and Cialis. Uh, Women don't really have that much to talk about or that or products out on the market, and it's maybe embarrassing for them. So we may need to ask some open-ended questions about their sex, their sexual desire, and whether or not they've been able to achieve orgasm. And in order to ask questions like that, you definitely need to have a relationship with your patients. Patients may not even have a good knowledge of their anatomy down there. So I'm a very visual person, so showing someone a diagram or a picture of where the stimulation needs to be intensified. Many women may not realize that the likelihood of having an orgasm strictly by intercourse is very low. Women typically need stimulation, clitoral stimulation, in order to have an orgasm. And there are products on the market. Zestra is one that is used to help increase sexual desire in women. They call it a female Viagra. I don't know if that's true or not, but that's one of the things that is out there. They also talking about lubricants. If a patient is sexually active and is dry down there, using a water soluble lubricant is important. Anybody who's having intercourse, you want to stay away from petroleum um, lubricants like Vaseline, because if they're using latex condoms, that can actually break down the latex, and you're using that condom as a barrier method, so it negates any effect that you may have from that. So um, different things you need to speak about with your patients in that open environment. You don't want to have interruptions. You don't want phone calls. You don't want to be distracted. Um, that open environment, so patients feel comfortable, they trust you, and are open to discussing those things that are concerning to them. Okay, next slide. Contraception. Contraception is another reason that women come to their OB-GYN or to their female family nurse practitioner. Lots of nurse practitioners work in women's health. You don't have to be a women's health nurse practitioner in order to work in women's health. That's one of the wonderful things about being a family practice. You can take care of just about anybody. It's not just midwives that do it, or women health nurse practitioners. Family nurse practitioners have the ability to take care of women, and many of them work in OB-GYN practices, seeing patients for well exams and taking care of patients throughout their pregnancy. They just don't deliver the baby. So, different contraceptive methods that are out there. Well, of course, the pill is very common. However, there are issues, or there can be issues with the pill. I never realized how difficult it may be to remind someone that they have to take a birth control pill every day. And I learned that when I was working with a midwife. Many years ago, I was doing my training because originally I wanted to be a midwife. At least I thought that's what I wanted to do, until I worked in a midwife practice for a while, and then I realized it wasn't what I wanted to do. It was kind of tedious seeing the same types of thing all the time. I wasn't that interested in it. But anyway, I did realize that pharmaceutical companies were coming up with a whole bunch of different methods and little um, trinkets to try to remind people to take birth control pills, because these reps would come into the office. They would give away toothbrushes. Take your pill when you take your toothbrush or when you brush your teeth. And I was amazed by that. And there are over 100 different types of oral contraception out there on the market. And it might be confusing to choose which one. But you want to use the one that causes the least amount of side effects. And an estrogen only contraception can cause uterine thickening. It can also cause some bleeding. Um, what I'm seeing a lot more now is the subdermal progestin implants. Those last for a long time. I think it's 5 years. The thing with that though is once they're removed, you may not be able to obtain a pregnancy for 10 months or so. So you may not have a period for about 10 months after it's removed. Also with the Depo shot, the Depo Provera shot is a progestin only contraception. It's an injection that's given every 3 months. You may get some breakthrough bleeding with that, and you may not get a period for, again, several months after you have stopped taking it. Depo has also got a black box warning on it. They have found that it is not advisable for use to use the Depo for contraception more than 5 years. It greatly increases your risk of developing osteoporosis. I really preach to my sexually active patients that if you're not in a monogamous relationship, that you should be using a barrier method like condoms. Condoms can protect you against sexually transmitted infections and HIV. Um, so I really push the barrier method for people who are not in monogamous relationships. Let's see. Let's go to our next slide. PCOS. And you're going to see a lot of patients that have PCOS. So these patients typically present with irregular bleeding. They may go months without a period, or they may have periods all the time. Out of these patients, you're going to find that they have an increase in hyperandrogenism. That means they're going to have facial hair, not always. 50% of them are obese. Um, they may have thyroid issues. Uh, when I see a patient like that, first thing I think of is PCOS, and I get an ultrasound on them to see what's going on. Infertility is also many patients don't realize they have PCOS until they come into the doctor saying that they've been trying to get pregnant with no success. And then they'll do some screens on them and find that they indeed do have polycystic ovarian syndrome. It's pretty common nowadays. I've been seeing different treatments out there for it. Birth control pills can help to regulate their period, and metformin also. I see these patients on to help with the symptoms. And with the facial hair, uh, Veniqua is a cream that you can apply that will help discourage the growth of facial hair. So, to definitely a topic to consider when you're taking care of patients with those irregular periods, overweight, and facial hair. I automatically think PCOS. All right, onward to the next. Sexually transmitted infections. Unfortunately, we see a lot of those in practice also. Chlamydia is the most common sexually transmitted infection that you'll see, um, and easily treated with 1 gram of Zithromax or azithromycin. Gonorrhea is the second most common sexually transmitted infection that you'll see. And it's interesting to note that about 64% of 12th grade students are sexually active. And that's more than 50% of students that have reached their senior year of high school are sexually active. And of that, 50% of them are going to end up having had an STI at some time. STIs increase the risk of pelvic inflammatory disease, and especially in the pediatric patient or the pediatric population because of their reduced immunity. So we really, really, really need to teach about sexually transmitted infections. If you have a patient that's coming in, I mean, I had a patient that was coming in every 3 months, she was getting checked for sexually transmitted infections. She was not monogamous. In my conversation with her, she said she probably had about 4 sexual partners every 6 months. And I asked her, "Are you getting checked for HIV as well?" And she said yes, which is what they should be done. People who come in and get screened periodically for STIs, because they want to be safe, they want to practice safely, they should be having an HIV screening done also. HPV is another big thing. And there are vaccines out there. It's a vaccine that really is not being utilized as it should. We are strongly encouraging that 11-year-old girls and boys get vaccinated. It's a series of 3 vaccines. And the problem with that is, though, we know that it gives you protection for about 5 years. Okay, so if I'm giving, we want to immunize people early so that they are protected before they become sexually active. I understand that. But if we don't have any evidence that it is effective longer than 5 years, we may end up having to give them a booster. And we're not doing that now, but this is something that's out in the community right now. They're investigating. A booster may not be indicated, but maybe it is. So that is something that you'll be probably hearing more about um, as time goes by and they learn more about the vaccine. It's a relatively new vaccine. It hasn't been out that long. All right, let's see. Slide. Painful menstruation, pelvic pain. Well, this is also a common occurrence for people to come that they come in to visit you is this pelvic pain. For me, I always think ovarian cyst. Cysts are very common. They may have an increase right before their period. So I like to have these patients get intimate ultrasounds. That's what they call them now. They used to be called vaginal ultrasounds. Now they call them intimate ultrasounds. But I like to do that just to rule out that there's a cyst. With an ovarian cyst, they have the pain, but they don't have a fever. Chronic pelvic pain can also be caused due to physical abuse. So, again, this goes back to the interview portion of our presentation. We need to have that type of a relationship with our patients that they feel comfortable communicating with us. And you can see in your book that there are all types of different screenings in there. The problem with trying to interview patients and determine whether or not there is a potential domestic violence issue is that patients who are in those types of situations, the potential abuser is often there with them because they're very controlling. So getting that patient alone may be difficult. I have actually asked for a urine specimen, taken the patient to the restroom, and while we're in the restroom giving instructions, asked them there if there's anyone that they're afraid of. That gives me a chance to give them some time. So, if the patient's experiencing pelvic pain or and has had an ultrasound, we've ruled out things like cysts, then we may need to do a laparoscopy. Now, in that case, we're going to refer them to the gynecologist obstetrician. That's going to rule out some things like endometriosis. Again, a very common occurrence in women. Um, they don't really know a lot about endometriosis except that it is uterine tissue actually that grows outside of the uterus. And there is a theory out there that states endometriosis is caused by retrograde menstruation. So that is menstrual fluid that flows into the abdominal cavity and kind of takes hold in there. Patients at risk of endometriosis are those that have begun to menstruate early, and it's a very common occurrence. But we want to do that laparoscopy to see if um, endometriosis is indeed the cause of the pelvic pain, and that gynecologist will often zap some of that tissue in there that will give them some relief. Um, some other things that can cause pelvic pain is irritable bowel syndrome, another thing to be considered with patients. So, um, even though this is a women's health specialty, you have to think outside the box because there are other things. There's an appendix, there's a bowel there, there are ovaries there. So, again, the cyst, or, I always am concerned with ovarian cancer. I've had a very dear friend of mine pass from ovarian cancer, and it is the highest rate of mortality in uh, women's cancer. So it's not the highest diagnosed, but it's the high. It has the highest mortality rate. The problem with that is that by the time it's discovered, it's generally spread already. Um, my physician friend of mine, my one friend who passed from ovarian cancer, a lot of my friends, we go to this physician, and she really has become hypersensitive to ovarian cancer since my friend had it, and she had been having abdominal issues for quite some time. So my physician friend, almost all of us, we get intimate ultrasounds at every visit just to make sure that our ovaries look okay. And let's see, I think that's enough on that topic. Let's move forward. I want you to know basic female anatomy. I think that will be helpful. And also, when you're performing an exam, I also teach health assessment. And I teach my patients that the first thing you do is use your eyes, or not my patients, my students, sorry. Use your eyes to see that patient, observe them as they're walking into the room, their affect, their demeanor, their body language. So we're using our eyes first. Then we're going to use our stethoscope and listen. Then we're going to percuss. And then we're going to palpate. So if you follow that order in just about everything that you do, then you'll be good. Also, how do you choose what type of a speculum to use? Well, if you have a woman that has not had a baby before, in all likelihood, you're going to use a Pedersen speculum. Most practices now use plastic speculums, and they may have small ones if you're using it on young teenagers. They may have larger ones for morbidly obese or multiparas. If you have a patient that's had 4, 5, 6 children, when you put the speculum in, the tissue in there may fold in on the speculum. So they do have larger speculums, Graves speculums, that are easier to open up so that you can see that tissue better. And another thing I want you to know too is hormones with menopausal women. Now, it's the big debate out there, and this isn't really stressed a lot on the exam. I'm just saying this because I think it's important for you to know. There's been a lot out there the last 10 years about hormones, and they are cancer causing, they cause all sorts of things, and uterine cancer. And that may not be the case. If the patient does not have a strong family history of breast cancer, if the patient has a negative mammogram and she is really suffering from the signs of menopause, which are typically the hot flashes, mood swings, um, putting them on a estrogen is not going to be detrimental to her health. The one thing that you need to keep in mind, though, is you can't just put her on an estrogen. You have to put her on an estrogen that has progesterone in it, because if it doesn't have the progesterone in it, then it increases her risk of uterine cancer. But I'm not afraid of taking hormones. I'm not afraid of prescribing hormones. It's not something that should be given across the board like it used to be, but if the patient doesn't have a lot of risk factors and the symptoms are making life just miserable for her, then I certainly would. So that concludes my presentation on the final exam review. If you have any questions or need any clarity, please don't hesitate to contact me. As you know, the best way to get in touch with me is either through email or sending me a text message. And this test will be open on the day that you are to take it. I'm looking at the schedule right now. And the final exam is going to be online November 5th. So I will open it up It is timed. It's a 50 question test. I give you about an hour and 10 minutes to take it. And if you have any difficulty getting into it, let me know. Otherwise, good luck, and I'll speak to you soon if you need to speak with me.